Mostly what we use are, risk calculators that are based on family histories, genetic background, et cetera. So Gale model, one risk calculator, TC8, probably the more commonly used risk calculator now. And using TC8, you're gonna determine about 12% of 12% of women have high risk, and what that is, a 20% lifetime risk. Now the issue there is that one, most breast cancers are spontaneous or not related to a family or genetic history. So that whole group is not involved in the assessment to begin with. And two, it's a lifetime risk. Now, I talk with women who come in high risk, especially the younger women, and that's really not so actionable in the real world. Knowing that you're high risk is definitely a bit of personal health information that I think everyone that I talk to wants to know. The women want to know this. Your patient wants to know what their risk is. Knowing your lifetime risk is helpful, but how actionable is that when you're 35? Compliance is notoriously difficult in high-risk centers, and part of it is because of this extended period of risk. Now, the other thing here too, when you're using it, you've got to enter this data. Somebody's got to collect this data. Somebody's got to get the questions answered from the patient. It's got to go into the chart. So right off the bat, when you start to use risk, profound risk for risk assessment, not only does performance exceed TC8. So if you believe in TC8, you've got to believe in this risk profound, because it does a better job. And of course, AI can detect breast cancer on a mammogram. I don't think we need to discuss that at this point. The other thing here, obviously, is there's no data input on your end. It's patient has a mammogram, it pops up. Nobody has to do anything. You don't have to hire anybody. It gives you a number that's more actionable across the board, and I think especially in younger patients. And the big part of it that's more actionable is that you're talking about something in the next 1 or 2 years.